Hello, everyone. I'm Dawn Semenko, the LFA Wisconsin Chapter CEO. Thank you for joining us for this month's Let's Talk About It webinar, Lupus, Heart Health, and Stroke Prevention, brought to you by the LFA Chapter Network. I'd like to introduce our staff members who are with us today. Betsy Woody is our Health Education Coordinator, and Angie Eckley is our Administrative and Content Coordinator, who both will be helping out with Q&A. Just as everyone's lupus is different, so are the medical and therapeutic treatments for lupus. Your physician knows your medical history best and is the best person to help in the treatment of your lupus. You can discuss information learned here today with your doctor, but do not make any changes to your medication or treatments without first consulting your physician. This webinar is being recorded. Presenting today is Dr. Christie Bartles, who is Chief of the Department of Rheumatology within the Department of Medicine at the University of Wisconsin-Madison. She is interested in systemic lupus erythematosus, rheumatoid arthritis, and reducing cardiovascular disease and disparities. In addition to her many research and teaching duties, Dr. Bartles serves as a member of the Scientific Advisory Council for the Lupus Foundation of America. And you can find her and her family selling raffle tickets and checking in participants at many of our Wisconsin chapter events in Madison. Following Dr. Bartles' presentation, we will open it up for questions. And if you have one, please click on the raise your hand icon or type your question in the Q&A. Welcome, Dr. Bartles, and thank you so much for sharing your time and knowledge today.
Thank you, Dawn, for that terrific introduction. And thank you for even the shout out for my family. They'll thank you as well. That's fantastic. Well, great. Well, it's my pleasure to visit with you all on a topic that is near and dear to me, and that is lupus, heart health, and stroke prevention. Just to get us kicked off, Dawn already shared with you that I am a rheumatologist. I'm a health services researcher and the chief of rheumatology at University of Wisconsin. But one of the things that really grounded this interest area for me was really that one of the first studies that I did actually was here in Wisconsin, and I was looking at the question of what predicts heart attack and stroke risk in lupus. And I was actually just doing a description of the 200 cases of lupus that we were using for that first study. And interestingly enough, we ran across a finding, which was that there were heart attacks and strokes that had already happened up to 2 years before lupus diagnosis in those patients. And up until then, the mantra had been that heart disease was really something that happened after about 10 years of lupus, that they were saying early on it's complications of the disease or infections, and later on it's cardiovascular disease. And our finding was something that was kind of a paradigm shifter that said, boy, heart disease looks like it starts early. And subsequently, that finding has been replicated actually in a Canadian cohort and at least 2 other US cohorts, showing that in fact, heart disease starts very early in lupus, which really makes it incumbent on all of us to learn more about what we can do to prevent that and help promote heart health and reduce risk for stroke. So a couple quick disclosures. One is that I've done some work through a mechanism called Independent Grants for Learning and Change through Pfizer to do unbranded tobacco cessation research. So just a quick disclosure there. I also will be showing you some work that's been funded by a number of different funders that are listed on the screen here. And my final disclosure is just a disclosure of my own personal lived experience, that I love this line by Senator Cory Booker's dad that says, don't walk around like you hit a triple, you were born on third base. And I realize that as a physician, I also was born on third base, and I've got some privilege in this world. And so I wanted, as I present to you all, to just acknowledge that as I walk through the slides that we'll be sharing this evening too. So as we talk a little bit tonight, the goals I have are threefold. The first is just to tell you a little bit about what we know about lupus and treatments and how those impact heart disease risk and stroke risk. The second is I'll tell you a little bit about what we're doing about it here in our UW rheumatology clinics and what I'm doing with the US rheumatology community to think about prevention on a larger scale. And then finally, I'll share some personalized tips about maintaining healthy hearts and brains, and we'll go through that. As we go through tonight, you'll see some different slides, many of which have the attributions on them. But if you're interested in learning more, I would really encourage you to take a look at the Go Red for Women American Heart Association, a website that has a lot of information for general heart health tips, and then also other websites, including the Lupus Initiative, that have other more nuanced approaches as well. So whenever we think about lupus, it's easy to think about it as, a disease that affects the joints, that causes some fatigue, some muscle pain and skin issues. But I always cue in my colleagues and actually trainees, and that again, also lupus can affect any organ system, but in particular can attack different areas that are in the vascular system that have blood vessels. So interestingly, stroke risk, atherosclerosis, which is another word for the plaque and cholesterol buildup in the heart, high blood pressure, and having kidney problems are all things that can be associated with lupus as well. And so just a reminder that all of those things are kind of the focus of our talk this evening. And when we think about that mechanistically, the things that are driving that are both traditional risk factors, things that affect everybody, that make heart disease one of the leading causes of death in the United States, and also some lupus specific factors that make it happen faster and more frequently in people with lupus. So just to kind of remind us again, typically when your own docs are thinking about who's at risk for heart disease, they're going to think about older men. And this is one of the places where young women with lupus need to sort of be aware that they've got some increased risk, because it may not be the first thing that people think of if they present with an atypical chest pain syndrome, for instance. Secondly, it's just knowing the typical risk factors and just reminding ourselves, and we'll talk about these as we go this evening. So high blood pressure, high cholesterol, smoking, high blood sugar or diabetes, abdominal obesity or high body mass index, physical inactivity, and then family history of heart disease are all the things that are on that traditional risk factor pathway, which again also impact people with lupus as well. But on the right-hand screen in the blue, you can see that how long you've had lupus, how active that lupus has been, how wildly revved up your immune system has been. All of those things are going to also affect your likelihood of having heart disease from lupus. One of the things down at the bottom here that I think is worth mention, and we'll talk about it a little bit later as well, is that also this HDL cholesterol, which I always remember as the happy cholesterol. This is usually your good cholesterol. So HDL is happy cholesterol, usually your good cholesterol. Interestingly, in lupus patients is not as protective as it is in other patients. So I'll talk to you more later, but the nice thing to know here is that sometimes I hear primary care docs saying, I'm not going to put this person on a treatment because their HDL is high. And the trick is that women with lupus can sometimes have a high HDL that's not protective. And so we want to make sure that we're still treating them if that ratio is elevated. And we'll chat more about that toward the end of the presentation today too. And when we think about how these vascular changes happen, we mentioned, it's both traditional risk factors and the lupus itself, but we think about it and basically we can have increased disease in any organ that's got a lot of density of blood vessels. So we've got heart density of blood vessels. We've also got a ton of blood vessels in the kidney, and maybe this is obvious and maybe this isn't obvious, but the kidney is a filtration system. So it's just loaded with tons of little tiny vessels that can get gunked up either with cholesterol or with clotting problems if folks have clotting problems, or with shear force if you've had high blood pressure or something that's kind of battering those vessels. And likewise, stroke risk can be part of that piece too. So anything we can do to reduce blood pressure, reduce cholesterol, and reduce that systemic inflammation can really make a difference. And we'll talk through some practical tips on that as we go. But I think it's worth just kind of thinking that through as far as where do lots of vessels that are really important live. So again, I told you one of the early findings that we had that was really important was this idea about timing with heart disease and lupus, and the fact that it is accelerated, probably a decade earlier than peers. And so women with lupus, as we mentioned in our Wisconsin cohort, were starting to get heart disease and stroke even 2 years before their lupus diagnosis, and that was in a Wisconsin cohort. In this study, Dr. Shivani Garg, who's the director of our lupus clinic here, worked with some folks at Emory in a cohort from Atlanta. And Dr. Garg and I worked with Dr. Sam Lim at the Emory Grady system, and essentially looked at timing of cardiac events across his entire cohort in the Atlanta metro area. And essentially here you can see stroke in orange or peach. You can see ischemic heart disease, which means heart attack type events, in blue. And what you can see is, again, she saw those in even 2 years before lupus. Then she saw the next peak actually 2 years after lupus, where there were a lot of stroke events here you see in that orange bar. And then we saw some consistent elevation in that 10-year post-lupus period, which had been previously reported. So you can see here that it starts early. It may peak actually far earlier than what we thought previously, and then it remains increased throughout the disease course for women with lupus, or actually all patients with lupus. The other thing that was observed in this study was that actually there was this disparity that was observed, that there was 18-fold higher risk in Black patients versus white patients in this Emory cohort. And so this is something to know as well, that this may be something that disproportionately burdens patients of Black race or ethnic minority rate background. And so again, just recognizing that this may be one other story where we really need to tune into helping to reduce disparities in the United States healthcare system. So this is another study that really talks about that disparity piece. And then I'm going to pivot and tell us a little bit about what do we do about this. But this is a really interesting study that was done where they basically looked at the likelihood of getting harm and in organ damage in patients with lupus. And what they saw was that African descendants living in the US did worse than African descendants in 11 other developed countries. So there's something additionally causing health disparities in the United States. And so I'm just going to point that out first, more risk in folks there. The second thing, though, is actually maybe the mixed good news, bad news, is that hydroxychloroquine was protective, about 40% less risk of organ damage. Steroids increase likelihood of organ damage, and high blood pressure increased risk of organ damage. So again, some things we can do to help prevent, some things that we might try to do to reduce harm, and some cues come from this study, which is basically another epidemiologic study. I promise you, I think this is the noisiest data slide on in the deck, but this is one of my favorite epidemiologic studies that really drives my two interests: one in promoting health equity, and two in reducing cardiovascular disease. So one of the ways that we're trying to address those two things, both quality and improved outcomes for patients with lupus, but also equity, meaning that we want all patients with lupus to have equal chances of having great outcomes. So I've been working with the American College of Rheumatology and Dr. Janusi Yazdani, and we've been working on creating some digital quality measures. And specifically, 2 of the 3 measures that we're recommending actually address this heart health issue, and I'm going to share those with you here. So nationally, through the ACR and the Centers for Disease Control, the first measure is just trying to make sure that all patients adult patients who have lupus have a prescription for hydroxychloroquine, unless they have a contraindication. So again, rarely people have eye toxicity or have a true allergy and cannot take hydroxychloroquine, but most of the time folks can take hydroxychloroquine. And what we know about hydroxychloroquine is that it helps control your lupus. It limits clotting, which is sort of interesting. People may or may not know that it kind of limits the platelet clotting. It can reduce your blood sugar. It can improve your cholesterol. And it actually, in epidemiologic studies, people live longer when they take hydroxychloroquine. So this is just a quick little reminder that we said, you know, if we could get a couple basic things out there and benchmark every rheumatologist in the United States, this is one of the things that we think is incredibly important. So this is the first one that we recommended. Now here at UW, again, Dr. Garg, who I mentioned earlier, and I helped mentor on some research, Dr. Garg's been working with patients to say, how do we get the word out on hydroxychloroquine and how protective that can be? And how do we use tools to sort of tell that message in a really easy way? So one of the tools that we're working on is this thing called a pictogram, where we show pictures about how protective things like hydroxychloroquine can be. And what you can see on the left is a 30-year image of patients not taking hydroxychloroquine, where about 30 of 100 patients with lupus would be expected to have a blood clot complication. So that could be a stroke, a heart attack, or some sort of blood clotting event, maybe a leg clot or a lung clot. But when patients take hydroxychloroquine on the right, you can see that 25 of those 30 clots actually could be avoided just with the use of hydroxychloroquine based on our epidemiologic data. So we have other images like this, but I just am using this to just kind of hammer that point home that one simple medication can give us a big bang for the buck as far as long-term protection. So don't give up on hydroxychloroquine. Even if you're going on to other therapies, it can have some great long-term outcomes and some protection for folks. And so that's the first take home. The second thing that we looked at as the second of the 3 ACR quality recommendations was really looking at the idea of steroid excess. And what we know about glucocorticoids or steroids is that if you take too much steroid for too long, it can increase your risk of getting diabetes. It can make your blood pressure a bit high. It can drive up that bad cholesterol. And we do know that it increases risk for things like heart disease and stroke. Now, there's certainly times when you have to take prednisone, right? There's certainly times where you've got end organ disease and we need to get ahead of it. And so early, we can use glucocorticoids, but the measure actually says that by month 6, in most patients, we should be able to get that dose down below 7.5 milligrams. And 7.5 milligrams was recommended by 4 different global guidelines because it's got evidence that it reduces the likelihood of end organ damage, heart disease, and again, reduces risk compared to higher doses. And so again, the second most important thing that we said we needed to look at as a quality measure was just making sure that patients don't get left on too much steroid, where the steroid itself, rather than the lupus disease, might be a driver of some of that risk for heart disease and stroke. I'm getting a couple nods here. So that, yeah, that's kind of loud and clear. So some just kind of simple things to say, as a healthcare community, we need to have some policies in place that can help drive quality and improve outcomes for patients. So these are the couple things we're doing in that space. Now, the other thing that our group has done is done some research on smoking. And interestingly, we did this study where we actually looked at how the correlation between number of pack years smoked and the likelihood that, or how fast you get damage. And so if you see in the red line here, these are actually non-smokers, versus in the blue line at the bottom, these are people who smoke. And the people who smoked more than 10 pack years got damage to their organs 7 years faster than people who never smoked. So this is sort of interesting. The other thing you see here is that these go in a nice little linear order, right? You can see they just kind of line up, bing, 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 which tells us that there's a dose response rate here too. So what the take home message I would say to patients is, number one, it's best if you've never smoked, and then don't start. But number 2 would be that if you can quit and you can reduce your lifetime exposure, you probably reduce your lifetime harm. So if we can help you cut back, or if we can help you quit, it could really make a difference in the likelihood that you'll get long-term damage, including heart disease and stroke. Mm-hmm. So when we brought this story to patients and patient focus groups a few years ago, what we heard from patients was, I had no idea that no one had actually talked to them about the way that smoking interacts with their disease, or how smoking actually might make their medications work less well. For instance, we know hydroxychloroquine doesn't work as well when people continue to smoke. So interestingly, patients said, I had no idea. Every day, I wish these meds worked a little better. Some of these meds are kind of expensive, and boy, I wish someone had told me that. So that's an interesting thing. What we heard from nurses and was that, we care, but we don't really have time to follow up. So that was kind of an interesting thing. And what we heard from the medical assistants, the people who were kind of day in, day out, taking these histories from patients, they said, we really don't know what to say. When a patient says, yeah, I smoke, we kind of go on to say, do you have any allergies, right? We don't really know what to do next. And so we said, we can help with that. We can help you figure out how to help get people connected so that they've got the resources. And that's one of the things that we've been doing locally, and then spreading that idea nationally as well. So one of the things that was a newsflash to me was that, among people who smoke, 70% consider quitting each year, and half of them will try, which I had no idea it was that high. But the fact of the matter is that if they can get help from a quit line or some other resource, they are 4 to 6 times more likely to quit for good. So really connecting people to resources that could help support them can make a huge difference. And we've been really lucky to partner with our state quit line, which can send tobacco replacement therapy, nicotine replacement therapy, and actually have a phone coach call the patient and tailor a treatment, which is pretty amazing. And that's a free service. They get, here in the state of Wisconsin, they can get 4 weeks of nicotine replacement. Other states that we've been working with can get around 2 weeks of free nicotine replacement. And again, it's a great jumpstart to help people quit smoking. So it turns out that when we do that sort of warm handoff, where we have the quit line call the patient, we send it as a medical order through the electronic health record, we send it over, patients are 13 times more likely to actually say yes than if I hand them a brochure, which probably goes in the trash on their way out my door, right? If I'm very honest about that. So this warm connection has been really important, and we've been doing that and replicating that in a few health systems. Using this approach, we've been able to increase quit line referrals actually 20-fold, which has been pretty amazing. And I also love this because this is a health equity thing too, that a pack per day smoker spends $4,000 a year on cigarettes. So what I tell patients, and also what I tell my staff, is this is something that I can do to pretty dramatically improve the quality of life for my patients. There are very few things I can do for patients. I can't even think of any others off the top of my head that could put $4,000 in an individual patient's pocket, but this is one of them. So this is just a good take home. Maybe for those of you who lead support groups and things like that, that's just a good thing to sort of keep keep in mind. And, you know, again, we can also improve health and we can save them money, which really makes a difference. So one of the ways we've done this is to, again, we don't want to harass people who are already stressed out maybe about their lupus, and then they happen to smoke and they feel stressed about this. But one of the ways we've found out that is just sort of a low barrier is just to ask patients in clinic, have you thought about cutting back or quitting in the next 30 days? And it turns out when we asked this question that already existed in our health systems electronic health record, but we were never asking it. When we started asking the question, 1 in 3 patients actually told us they were thinking about cutting back. And when we make the offer to then connect those patients to resources, up to 80% of them said yes. So it's kind of cool. So just a really simple thing. It takes 90 seconds for my staff at point of care, and it's pretty dramatically improved our likelihood of getting people connected to resources. And I just spoke to a patient actually last week who told me that she for years was being told, like, you know, you should quit, and felt kind of preached at. And she said, you know, I'm actually thinking of cutting back and quitting and getting support from your quit line. And it's just because you've asked it in such a better way from the last few times I've been in clinic. It's like, well, lovely. We've invited that conversation. So that's that step. We've been able to replicate this, as I mentioned, actually in the Gunderson Health System. This is a quick shout out to Dr. Doug White, who is now the president of the American College of Rheumatology this year. He's here in Wisconsin, and we've replicated it in his community health center. And we've also recently been able to replicate this at the Grady Health System, which is a safety net hospital in downtown Atlanta. And we sort of talked about this. This was stress testing our intervention, that if it would work at Grady Public Hospital, which has a huge lupus clinic where they see 40 lupus patients in a day with like 2 medical assistants, and they are clipping. They were able to do this and replicate this as well. And they very dramatically had over 100 referrals to Quit Care. So this is really something that could be scaled up in other health systems, and we're hopeful will be a model. And to date, we've had more than 300 referrals in the state of Wisconsin and Georgia from rheumatology clinics. So we're pretty proud of that. So the next pivot that I would love to go to for you all is to give you kind of share some more quick facts, just thinking about high blood pressure. So we could ask the question here, you know, if I could see all of your faces, I could just ask you, you know, how many of you know someone with high blood pressure? And I think that probably almost everyone's hand would go in the air, right? It's a pretty common thing. It turns out 1 in 3 adults have high blood pressure. And by the age of 55, half of adults have high blood pressure. So really common, and especially common in patients with lupus, in part, as we mentioned, because they have some increased inflammation in the blood vessels, but in part also from medicines, things like glucocorticoids that drive up blood pressure, or NSAIDs that people take for pain, things like this. So the trick with high blood pressure is that 1 in 5 patients don't even know they have it. Right? So this is one of the tricks with it. The second thing is that among people who do have it, even if they're taking maybe one medicine, about half of them have it controlled, which means half of them don't have it completely controlled. So they need more medication, or they need a different medication, or different combinations. And we haven't always been great as a health system, I'll just be very honest with you, of saying primary care and specialty care, let's work together to control high blood pressure, knowing it's one of the most controllable and fixable parts of preventing heart disease and stroke. So knowing it's the most common comorbidity, and it's the number 2 cause of death, second only to smoking, which we just talked about, we also set out to say, hey, what can we do to do a better job taking care of this? And one of the things we did was, again, go back to patients to say, what do you think about this? And interestingly here, patients told us things like, hey, I get my blood pressure checked twice a year in rheumatology. They would tell me if I have a problem. And the trick was that when we talked to rheumatologists, they said, well, sometimes I send a note, but sometimes they weren't, right? So this is sort of a trick. So patients were expecting it to be addressed or to be pointed out, and rheumatologists sometimes took it as their job, other times thought it was within the realm of primary care. And when we talked to primary care said, we don't see them as often as you all do. And in fact, just send them back. So we made a system to say, how can we alley-oop and get patients back to primary care so they can get better blood pressure control? And that's one of the things that we've also been working on. And sort of a message to folks on the call today would be, 1, just make sure your docs are working together, and 2, kind of be your own advocate, ask about those numbers. And we'll talk today about what those numbers mean as we go through. So hypertension, just get the wording and naming sort of level set. Hypertension means that you've had high blood pressure at more than one visit and it's been diagnosed by a provider, right? So you could occasionally, you've probably heard of white coat hypertension. You just get a little stressed out when you walk in the doctor's office and your blood pressure goes zip, zip up a little bit. You rest, you talk to them, you get the hard stuff out of the way. And then if we check your blood pressure at the end of your visit, sometimes it's completely normalized, just kind of sitting there and resting. But this would be people who actually have elevated blood pressure where we let you rest a minute or two, and then we come back and it's still high, or you've had it on multiple visits that it's been high. And then those are the folks that we should probably treat. And we can talk a bit more about that as well. So high blood pressure or hypertension refers to being high on either the top number, which we call the systolic pressure, or the bottom number, which we call the diastolic pressure. And basically there's a little bit of debate here, and we'll talk more on these different ranges, saying that ideal blood pressure would be less than 120 on the top and less than 80 on the bottom. Nobody debates, though, that everyone should be below 140 over 90. So we'll talk to you as we go through this, that again, we've used and sent people back to primary care to say, let's get everybody below 140 over 90. And then as far as fine tuning for that 120 over 80, we do try to tailor that over time, but we don't necessarily make you go for a specific visit. But just so you know, these are the ranges right now that are being recommended. And I'll show you another table on that from the American Heart Association as well. High blood pressure, again, chronic, ongoing, and sometimes can be addressed by healthy lifestyle. You could actually drop your blood pressure by 10 points by eating a low salt diet, something called a DASH diet. So that's kind of cool. But often it requires high blood pressure medications. And so we'll talk a bit about that too. The thing to know about hypertension is that usually people don't have any symptoms. And that's why hypertension has been called a silent killer, that basically your pressure gets high. Most people have zero symptoms at all. Occasionally, however, when it's super high, people can get fatigue, they can get winded easily, they can get blurred vision or headaches, they can have actual chest pain, or they can, again, feel really winded or short of breath. And again, here's a quick analogy to kind of help us put our heads around it. I think hypertension sometimes, since it is a silent thing, it also can be kind of invisible and people can't quite picture it. But one of the images that a nurse actually shared with me that I thought was kind of interesting to think about is basically, it's kind of like when you run your ribbon, your scissors across your curling ribbon, that basically that high blood pressure shears the inside of your vessel and causes it to get kind of inflamed. And so it can get corkscrewy and get really tight, which is hard to push blood through. You can imagine if it's corkscrewed and tightly wound. And then the second thing is it's got some snags inside that can catch those platelets and can cause clot, right? So then you're going to be at risk for heart attack. The other thing that happens to the system is the pressure just gets overloaded, which you can kind of see here in this silly cartoon. But basically when that pressure goes high, you can have strokes that are actually bleeding strokes, or have strain on your heart that causes things like heart failure. So if we kind of think about it as a pressure system, that's another way. So just two quick analogies to kind of help you understand why that matters. The other piece that I think is super helpful here, we talked a little bit about risk for heart disease, heart attack, heart failure, kidney disease, and stroke, which we know are all increased risk in patients with lupus. But specifically, there's 3 different types of stroke, and all of these increase in people who have high blood pressure. So the first is when you have too much pressure in the hose, you can blow through the hose and you can get a bleeding stroke called a hemorrhagic stroke, okay? The second thing is, as I mentioned, when you get all that shear force on the inside of that vessel, it creates little snags that the blood can clot to, and you can cause a clot that causes something called ischemic stroke, which basically means you can't water the garden territory downstream from the hose because you've got a blockage inside there, right? And the third is that if you've got a little bit of cholesterol, like I'm going to just be honest, like probably most Wisconsinites do because you live in the land of beer and cheese. But if you've got a little bit of cholesterol inside those vessels and then you've got high pressure in there too, you can actually, again, clot off that vessel from that process as well. And interestingly enough, the other piece here is that when you have lupus and inflammation, you actually can make the little scab that can sometimes stabilize that plaque less stable. And so those things can rupture more commonly in patients who have lupus than with everyone else. So it's really important, again, to control that cholesterol so you don't get that plaquing in the first place, control that blood pressure so you don't have so much shear force, and then take your hydroxychloroquine because we said before that's going to reduce the likelihood of getting clot, right? So those are a couple of things. High blood pressure makes you 4 to 6 times more likely to have a stroke. So if we can control that blood pressure, it's one of the best things you can possibly do to make it less likely that you'll have stroke over time. Now, I mentioned before, there's some different ranges that are in the literature for high blood pressure. So everyone agrees that every patient should be less than 140/90. So when we do interventions in our clinic, what we say is if you're higher than 140 on the top or 90 on the bottom, you need to go in to see your primary care doctor and get maybe a medication titration within the next month, right? So if you come to my clinic and you're high, I send you to primary care and you get remeasured and you're just fine. Maybe that's fine. But if you're measured and you're a couple times high, or you go to my clinic and you're high and I send you back to primary care and you're still high, you need some medicine to try to get that under better control. Or if you're already on medicine, you need to go back to see if you need a little bit more or if you need a combination. And sometimes people need more than one blood pressure medicine too. So that's what we call stage 2 hypertension. But here they're kind of pointing out that stage 1 hypertension is just anytime you're between 130 and 80. And again, anything they're going to call you high if you're greater than 120/80. So over time, we've learned that basically the lower the better for the most part for blood pressure. So 120/80 is kind of that normal number. If you kind of know the numbers, the goal is to get you less than 120/80. So as we implemented that plan where we said, you know what, if you're high, we're going to remeasure you right in clinic at the end of our visit, and we're going to see if you're still high, we're going to send you back to primary care. What we found was that patients were 2 times more likely to go back to primary care and actually complete the visit. And we also found that we reduced disparities, that actually patients of Black race and ethnicity had higher rates of hypertension. And the protocol worked great for everyone, but it worked particularly well for patients of Black race ethnicity. It also worked well for patients with diabetes. So people who had more than one risk factor, their rheumatologic disease and their diabetes, and then we still got them back. So this is a good news scenario where we can just coordinate the care between providers and get people what they need. We've been able to replicate this at the Medical College of Wisconsin, and we've also recently been able to replicate this in gynecology clinics, which is sort of interesting and I think relevant to the lupus population, because it turns out that if you've got hypertension of pregnancy, if you've never had high blood pressure after your pregnancy, you're still at risk for heart disease. So this is sort of interesting. Again, one of those things where you get a double whammy, but people who have preeclampsia, which we know lupus patients can get, or pregnancy hypertension, all of those things increase your risk. So we're partnering also with gynecology to say, let's help kind of close the loop on patients who have multiple providers so that we can help the system support patients as well. All right. So I'm going to transition us now to just talk about some personal tips. And on this one, Dawn is smiling because this is my team at the most recent Lupus Walk. And so this is our research team and our clinic team. And we were really proud to have a team for the Wisconsin Lupus Walk here in Madison. And we'll just pivot now and talk a little bit about individual strategies. I talked to you a little bit about policy strategies we're trying to attempt, clinic strategies, and now we'll talk more about one-on-one patient strategies to protect heart health and brain health. So the first is just to maintain a healthy weight. The second is to try to be active. And on be active, I know this is easier said than done because you can feel really fatigued with lupus, obviously have joint pain. And so this sometimes can be just a conversation that I have with patients where we say, you know, can we get you plugged in for water therapy so that there's a little less strain on your joints? Can we help you take an extra lap on the outside of the grocery store when you go grocery shopping so you get a little more physical activity, but you're not at risk for falling in the parking lot, for instance? So we have different ways that we can come up with some good strategies here. You know, walking counts. It's weight-bearing exercise. It's good for bone health, good for heart health, good for brain health. And so I often am talking to patients and say, you know, I ask them, would you be willing to set a goal? And when I ask permission to set a goal with patients, they almost always say yes. And then we can set a goal and say, okay, they're going to go walk 20 minutes. And if it's a good day, they're going to walk their 20 minutes. That's a plan A day. And if it's a crummy day, they're going to go walk 10 minutes. They're just going to do a little bit, but every day they're going to do just a little bit. Or, you know, if they make the goal of 3 days a week, and then I write that in my medical note. And the next time they come to clinic, we have a little personal accountability. And I say, hey, how are you doing on that goal that you set with me last time? And it's kind of a nice thing that's been great for a lot of patients. The third thing that's on this slide is that limiting salt. And I mentioned it before. You can look up this thing called DASH diet, and you can drop your blood pressure by 10 points just by reducing salt. And that's kind of a fun way to do that. Mediterranean diet also might decrease blood pressure. And again, as another heart healthy diet. And then limiting excess alcohol. So again, not to say you can never drink, but just saying that in excess, that also drives up high blood pressure and can be a risk factor. Avoiding smoking or reducing smoking, managing your diabetes, managing cholesterol. New risk factors for heart disease are actually, they're saying low sleep is a heart disease risk factor. I don't know if people have been reading this in the literature. It's been out for the last couple of months. And I actually am sleeping more to try to keep my brain healthy, because it's also a risk factor for dementia, even in the general population. But since a lot of folks with lupus struggle with sleep, I've been trying to address this a little more often too, to say, you know, how can we, and it turns out that if we can help your sleep, we can often help your pain. So we've been trying to address, you know, physical activity, sleep, kind of holistic care. But this is just one other reason to underscore that. The next thing on the list is limiting excess hormones. So if you don't need hormone replacement therapy after menopause, probably good to just hold off on that. If you do need it, obviously talk with your doctor and use as little as possible, as short a time as possible. If you need hormone contraception, absolutely, you know, just talk with your doctor about the safety of that and your choice. I love the Mirena IUD because it helps my patients not have estrogen on board with their contraception option. So again, lots of different choices in that discussion, but just to kind of point that out. And then finally, kind of bring us back to be sure you take your hydroxychloroquine. It actually has an amazing impact for such an old medication. It really is impactful. And then limiting those steroid doses as well. The next slide is actually from that Go Red for Women slide. And this is just to remind people, you know your numbers. So the numbers are on here, that the goal blood pressure, 120/80, like we talked about before. The goal body mass index. So again, you're kind of, it's a height to weight ratio is 25 kilograms per meter squared. Here at UW, that'll print on your after visit summary for some of you that might do the same in your health system. So you can talk with your doctor. How am I doing on that? Keeping your blood sugar less than 100. And then finally, this cholesterol, managing that cholesterol with a ratio of bad to good. And I mentioned earlier, but I'm going to say it again, that don't let the high HDL fool you, because in lupus, often that HDL is not as protective as it is in everyone else. So if you have high triglycerides or high LDL, which is the bad cholesterol, have your doctor go ahead and treat that, because the HDL may not be as functional as it is in other folks. So that's a good little tip. And you're going to be the expert in your own health, because not all docs know that. I will say that I've done a little bit of research that is actually quoted in the cholesterol guidelines for women and in the US cholesterol guidelines. And so that's one of those little pearls, is just saying, you know, check cholesterol often in folks with lupus, because it makes a difference. All right. And with that, the other thing I'm going to just point out and just salute the folks at LFA is really walking matters. And so, you know, if you have a walking team or some accountability and can do that as part of your socialization and your connection with your constituents, if you're leading lupus groups, it's incredible, right? So there's programs through places like the Arthritis Foundation called Walk with Ease that you can look up, and you can have a walking schedule that gradually builds up people's endurance. Just walking without a program obviously has some benefits. And then obviously when you can get both the social aspect and the physical aspect, it can be a win-win all around for patients, and a lovely way to raise funds and awareness as well. But just a quick plug for the power of walking. And finally, you know, just a quick summary slide of what we've covered for territory before we'll take some questions. So as far as what we've covered today, we've talked a little bit about research findings where heart disease and stroke start early. They may start actually even while you're developing lupus, or within that first couple of years before lupus starts. The second bullet is just to point out that there are some health disparities, that the patients who are of Black race may have even higher risk. And so just making sure that you're aware of that, and talking with your doctors and team about what we can do to help promote health, and that damage happens even faster in people who continue to smoke. And so if we can help reduce, either cut back or quit, that would be beautiful to reduce that risk. Next, we talked a little bit about those clinical and policy changes where we can double timely follow-up, and we can all be part of that team to just make sure that we work with both primary care and our specialists to get follow-up for that. We can increase use of things like the free quit line, where we can get some tobacco cessation resources if we need it. And then we can work with our national bodies to just make sure that we're driving things that we know improve quality of outcomes and also promote health equity. And on that note, you'll notice too that with Pride, I showed a lot of pictures here too, but we also are using this research to really build up the pipeline and build the workforce, and really hoping to make that workforce as diverse as possible to help really personalize and tailor care with the populations that we're serving. And we're really proud to be doing that. So with that, I will show you some various members of our team who've been working and partnering with us in this research. And huge thanks to all of them and to many of our funders. And with that, I will just pause and take any questions. So thank you.
I'm looking at the Q&A and I've got several questions, Dr.
Okay.
Bartles.
Great.
The first one I have is, this person has taken Plaquenil or hydroxychloroquine for years, but they had to stop due to the effect on their eyes. So is there any good alternative that will provide, I guess what you were saying were sort of the benefits of Plaquenil as far as being sort of a preventative for heart disease?
So I'd say probably two things. One is just to, make sure that you get a really great eye exam before you call it quits on that, is to get an ophthalmologist. So an MD eye exam to verify that you really truly have retinopathy, but I'm going to assume that's already happened in this case. And if that's the case, they're right that the hydroxychloroquine is then off the table. Things that are also antiplatelet would be things like low dose aspirin or baby aspirin. So that person could definitely talk with their doctor about the appropriateness of considering something like that, like a baby aspirin as a preventive. So that might be a consideration as well. So great question. But for everybody else, getting a really good eye exam and taking the hydroxychloroquine unless there's an absolute reason to not. That's a great point. Thanks, Betsy.
Yep. And I have a couple more, and I'm going to piggyback on that just because of the support group I run. I know a lot of people quit taking their hydroxy. This is something just for you guys to know, running clinics and stuff, because they feel like it's not really doing anything. They don't see the effect of it making them feel better. I'm really so happy to hear this discussion where I can say, hey, you don't know what it's preventing you from getting, you guys. It really has a very, very valuable. I have never really once heard how valuable hydroxy was for both your heart and your blood pressure, vasculitis, all of that. So I think that's just, I'm so happy to have this information so I can tell people, you might not feel like it's taking away your pain and things like that, but it is really preventing some serious issues down the road. So
Exactly.
I think that's something that really, I've never heard in my office. It really needs to get stressed so that I think the folks really know that that's really a preventative therapy as well for 5, 10, 15, 20 years out as well.
Absolutely. So Betsy, that really well said. And we're trying to do a better job of communicating it. It really, honestly, what you're saying is exactly what we've heard from patients in focus groups too, that they just didn't know. And so, boy, we're really trying to get the word out and use unique things like the pictogram I showed you in different ways and different strategies to communicate that message. Because boy, we've kind of failed as docs sometimes in getting the message out on that. So you're just right. And we're even if your pain isn't perfect every day, keep taking it because it's behind the scenes working for you to protect your organs. 40% less likely to get new organ disease, which is amazing. In Canada and places where they have huge national data sets, they've shown that people live longer when they take it. I mean, like there are some hard and fast benefits, which is great. So Betsy, thank you. Well said.
Yeah. And I think that pictogram was great. Like if I were you guys, I would try to find a way to have that in every single doctor's office because a picture is worth 1,000 words right there.
Absolutely. We're working on that. We were just talking at the ACR meeting, Dr. Gard presented this and we're talking about disseminating it through the ACR, like putting it on the website so people could just download it and use it in their clinics too. So stay tuned. We're going to continue to work in that space.
All right. I also have a couple more here. Is your data on hydroxy with a dose of 1 or 2 pills a day? So I guess they're probably asking, were you using 200 milligrams or 400 milligrams as?
That's a great question. So the jury, so this is a very great and timely question. So jury's a little out on that. So the eye doctors wanted us to dose reduce a few years ago. So some people did. There are new studies that are actually showing that flare rate goes up when you dose reduce like that. And so that's sort of interesting. The protection from clot and things like this, I think it was use of any versus none. And I don't think they parsed it out by weight-based dosing or whether you're on the full 400 or whether you take 300 a day or 200 a day. I would say work with your doctor to take an appropriate amount, and stay tuned, because that is an evolving discussion. What I'll tell you is from the ACR's perspective, we decided to not put a weight-based dosing measure in there. We would rather have people on as much as they need, rather than worrying about that. So on some, work with your doctor as much as you can tolerate, and they feel safe. But stay tuned for that. I think for a while they were saying 6 milligrams per kilogram. Now they were saying 5 milligrams per kilogram. I think that the pendulum may swing. So good question.
Okay. And then I have another one here. Is there a higher risk of heart disease after having COVID?
There actually is some increased risk for clotting. So yeah, so keep taking your Plaquenil, I guess, is afterwards. Just like as soon as you get it cleared, if if you took your Paxlovid for 5 days, if your doctor told you to hold off on your Plaquenil, then when you're done with your Paxlovid, go ahead and resume your Plaquenil afterwards. As long as, yeah. So it is sort of interesting. Yeah, that it does increase some risk. I haven't seen any differential data as far as clot risk in patients with rheumatic diseases compared to patients without. But I do know that, for instance, also steroids increase risk of COVID and then COVID complications. So again, another good reason to kind of use as little as you need.
Okay. Then another comment I have, or just a question, and this is from my personal experience. It just happened about a month ago.
Yeah.
I was just at my cardiologist, and I'm a huge workoutaholic, and my HDL is awesome. But she actually told me, you had mentioned that the HDL is probably not as good as we thought it was for years in lupus patient. She actually said they are now, as cardiologists, rethinking the whole HDL thing for everybody, not just lupus patients, but they're saying that ratio and that HDL, where we thought it was protective, we are finding, or they are finding, the whole school of thought for all cardiologists is evolving to like, yeah, don't feel safe because you have a great HDL. Nobody's safe.
Yeah, good. Well, Betsy, I'm glad that the word's getting out, then, at least in the cardiology community, but we need to keep the word getting it out to primary care too, because sometimes they'll talk patients out of something that would be a good idea for them. So
yeah,
good.
so I mean, and I know she particularly said even what she wanted to see for a cholesterol level for someone with no other risk factors. She told me having lupus is as big of a risk factor as smoking, in her words, so that she wants me even like, I can't remember what the exact numbers were off the top of my head, but she wanted me way, way lower than what most doctors want as far as cholesterol levels because of the lupus.
That's great. So LDL cholesterol, which is I said before, HDL is the happy cholesterol, the good cholesterol, but LDL is the sort of bad cholesterol. And LDL, for normal adults, they say, you just want it less than 130. And for people with lupus and RA, I try to say, that we want you for sure less than 130, maybe even less than 100 if you've got other risk factors. So that's exactly right. So we kind of tune into that. That's good.
And I have another question too. Have you guys broken down any studies to be like the different risks of lupus patients, those that have for like a high risk to stroke due to having a antiphospholipid antibody versus lupus patients who do not have that?
Yeah, absolutely. And I'm glad you brought that up, because I had that in a slide and then I wasn't sure if that was too busy, but you're exactly right. So people who have antiphospholipid syndrome, particularly those early strokes, I think that's a lot of times how that presents. And the trick, and so this is also probably a public service announcement to say, when you first get diagnosed, make sure your doctor has checked all of those, that you've had cardiolipin antibodies, beta-2 glycoprotein, and then a lupus anticoagulant test, that you've had all 3 of those tests to rule out that you've got a lupus clotting problem. Because if you do have a lupus clotting problem, they can either talk to you about either possible prevention measures, or if you've actually had, they can tell you about signs and symptoms to watch for, because Betsy, you're exactly right. That can be another risk factor. And that's a great point. So some of that is what I can tell you is that, for instance, on Dr. Garg's study, what we did with Emory, we did control for antiphospholipid syndrome, and it still was an increased risk. So yeah,
Okay.
so great point.
Okay. Here's another one just came in. Does having a positive anti-double-stranded DNA increase the risk more?
It does, actually. So there have been some studies that actually the double-stranded DNA titer and duration, right? So I think the other piece is, if it goes up, let's get you under control. Let's get you back on some medications, both, short-term, maybe some steroid, but longer term, some steroid sparing medicines to keep it low over time, because you're exactly right. That inflammation burden is not healthy for heart vessels and hearts. Yeah, that's great. Yeah, great question.
Okay. Does anyone else have questions? You can either raise your hand or you can write it in the Q&A session. So I don't know if most people know this who are there. We said that at the beginning of this presentation, but I just wanted to reiterate it because I think most of the speakers or most of the people are on mute. So you would have to ask your question one of those two ways, by either raising your hand or getting in the Q&A, and then I could verbalize it for you.
These are fabulous questions.
Yeah, this,
It's
Dr.
'cause we're a
Bartles, this was a great
fabulous group.
presentation. I learned a lot tonight. I learned really a lot.
Great.
Oh, can I ask another question? This is me. So I've had a problem sleeping for years, and it's my overriding concern because I've pretty well kept in check the other issues that are in my life. But having lupus and having a mom with Alzheimer's, I am typically up at 3 a.m. every day, and I start my day then, and I do not sleep. And I've been like this for 20 years. I know it's not good for my brain. I know it's not good for me and puts me at high risk, but what am I to do?
Yeah, so I guess one is, do you do a bit of aerobic exercise most days? Actually, I won't put you on the spot, Betsy, but what I'll tell you is these are the pitches that I make for patients. Let's just make it more broad. It's not just you, Betsy. Lots of people struggle with this. So I'll say one is I just make sure people are getting a little bit of exercise. And actually, if you can do your walking outside, so you get a little natural sunlight, that can help with circadian rhythms, and that can help your sleep-wake cycle a little bit. So that's one thing that I tell people, even just, a 15-minute outdoor walk in the late afternoon can sometimes help your sleep pattern. So that's one thing. A second thing would be to just have good sleep hygiene. So to just kind of hold yourself to a good standard. So one of the things I tell people too is, like, if you know you're going to wake up early in the morning, then just trying to get to bed, maybe shifting that by even an hour. The American Society of Sleep Medicine says that everyone needs at least 8 hours of sleep. And often I have patients with lupus who need more, which is, yeah. So 7 to 8 is what a healthy adult is, what the American Society of Sleep Medicine says. So what I tell people who come in and tell me they only sleep 4 hours a night, I say, hey, let's aim for 5. And we just set a modest target. And we just say, let's pivot back and start your time a little bit earlier on what you're going to try to lay down. So that would be kind of my second tip. My third tip would be that you could also talk with your doc about medicines. There's a little bit of controversy on whether or not melatonin might have any sort of risk with lupus. So I sometimes recommend it in people who have really mild lupus. I think it's probably fine. But in folks who have pretty severe lupus history, you could talk to your doctor. There's medicines like trazodone that are sort of low dose. They're kind of interesting, but they're an old school antidepressant that might actually, or nortriptyline, where they might actually also have a little benefit for pain, for chronic pain, and they can help you with sleep. So you can talk with your docs about those types of options where you might get, older adults. You're young, Betsy, but when I talk with people who are older adults, sometimes I give them a medicine called mirtazapine, which is an antidepressant that can help them sleep. They get a little mood boost and a little sleep boost. Sometimes that can be helpful too. So there's different strategies that are but in general, those are the kinds of things I talk to with my patients. Yeah, great question.
Thanks. I'm going to look again just to see if I've gotten any new questions. I have not in the Q&A.
And Angie hasn't had any hand raising. Right. Good.
Oh, and actually here, somebody has asked the question of what benefit does estrogen have for heart health? And so actually estrogen is a risk factor for heart disease. So probably not protective. So not no benefit for heart health on the estrogen. I think, so exogenous estrogen, so like pill form estrogen from birth control pills or from hormone replacement therapy. If you have to have it, talk to your doctor about it, but otherwise don't take it to try to, it's not a preventive. Yeah. The last one, I see one more question here too. It just says, my kidney doctor just recommended starting for Hygia. I'm currently in the process of seeing a cardiologist for low stamina and fatigue. Stress tests and thoughts on, is it menopause and lupus, or I'm sorry, one more, maybe the person can clarify a little bit there.
I'm guessing that is what it meant when they just said Meno and lupus. They can retype if they want, but yes, that's what she said. Yes.
Okay. Okay. So menopause and lupus, obviously lupus can cause early menopause. So women can get menopause, even a decade earlier than non-lupus peers. And so that's going to actually might increase your risk for heart disease as well, because of early menopause. So that's another reason we partnered with the GYN clinic, interestingly enough, because they see patients in the menopause clinic, and we just wanted to sort of close that loop. So talk to your primary care doctor, talk to your gynecologist, but again, these just good reasons to sort of reinforce things like exercise and diet and other good health habits that actually might help your fatigue. This is kind of interesting, but they've done studies that if people do just a tiny bit of walking, it seems counterintuitive. When you're fatigued, I tell you to go walk. It seems like a catch-22. But interestingly, if people do it and they do it in even small doses, it increases energy, it increases alertness, and it decreases fatigue. And there's almost nothing like, if I had a pill for fatigue, I would be a rich woman. But a walking prescription is actually one of the things that I could give to someone that actually might reduce their fatigue. So, so I would say a modest walking program might be one of the things that could be a huge benefit there too. And then on the med that you're asking a little bit about, I think that you're talking about a GLP-1 antagonist, and those are actually, that's a chronic kidney disease and diabetes agent, and those can be good ideas as well. So I think that's a reasonable, if your kidney doctor is recommending that, certainly consider that, because that can again reduce risk factors, because heart disease, kidney disease, diabetes, all those things kind of run together. So I think that's a perfect suggestion. So great questions nested in that one.
Oh, a couple more just came in.
Okay.
Do biologics, specifically Benlysta, increase your risk of heart disease?
So actually, stay tuned, because Benlysta does not increase risk, but as far as decreasing risk, we're not entirely certain right now. But what I can tell you is, in the RA world, the biologics actually prevent heart disease. So it's just like the tighter we clamp down on inflammation, it seems like the better off people do. Methotrexate, interestingly, decreases risk. Methotrexate was protective enough that they did a study using methotrexate even in healthy people, which is kind of weird to me, but healthy people who had like a high C-reactive protein. And so if you're on a little bit of methotrexate, that can work. Biologics probably also reduce risk. The one small molecule that would increase risk would be those JAK inhibitors, which again would be off-label use for lupus, but those actually increase risk of clot and cardiac disease. So be really careful. And we're not recommending those in people who have major risk factors. Yeah, but good question. Benlysta should be safe, but I don't know if it's protective. I think I would say right now, probably just risk neutral, probably a good idea just to control disease without needing steroid.
What is the best marker we have to just measure general inflammation? Would that be the C-reactive protein?
Yeah, that's a good question. So CRP, you certainly can measure that. It doesn't necessarily correlate with lupus flares. Some people it does, and some people it doesn't. So that's sort of interesting. And then the double-stranded DNA, you already heard, is an independent risk factor. So certainly that's a good one to kind of keep tabs on. So you could, I'd say probably either of those would be reasonable things to take a look at. Yeah. Yeah, great questions here.
Now we have another question. Imuran, same question.
Yeah, so azathioprine, that's an interesting one. I have not seen data one way or another on azathioprine or Imuran. So I can't comment on that, but I can do a little bit more reading and learning on that one. I do know methotrexate, definitely protective. I think that they've maybe compared it in the RA studies, but I don't know that I've seen it head-to-head compared in lupus. So I don't want to comment out of turn. Great question.
All right. Any more questions, you guys? I'm still here looking at it. So type away if you have one. Well, we've got Dr. Bartles here and all this information.
I think we've rounded out the hour.
I think so too.
Yeah. It's pretty good.
Yeah.
I just want to say thank you for the opportunity to come talk with you all, because this is obviously a topic that is near and dear, and it's great to get the word out on what we can do to have healthy hearts and brains. So
Well, thank you. And thank you everyone for joining us, and Betsy and
Yeah, thank
Angie
you.
for your
Thank you.
help.
And
I
thank you,
just wanna-
Dr. Bartles, for calling me young. I'm about to turn 60. I'm about to turn 60. So that was like, yeah.
Absolutely.
I
Well,
just wanted to remind folks to keep an eye out each month for the Chapter Network. Let's talk about our presentations. These are some really good presentations that I think are underutilized. So yeah, we'll be posting this. But thank you.
Yeah,
Thank
Dr.
you.
Bartles, thank you so much. I learned a ton tonight, and I had considered myself sort of knowledgeable about this topic, but I learned a lot of new information that was great.
fantastic. Happy
Right.
holidays, everyone. Thank you.
Thanks.
Thank you.
Thanks for all you're
you.
doing.
Have a
Thank you.
good night.
Bye-bye.